Friends. Thank you so much. I'm Amit Chakravarti, President of API, and thank you all for taking your a little time off on Sunday for this very educational and very appropriate program which we have. So we do API Advocacy Forum, where we tackle different topics which are pertaining or which are relevant to our day-to-day practice, which doesn't fit in any particular format. And we have done that in the past. We've done that for H-1B visa. We've done that for other areas of where we needed some education or help. We are going to come up with several more. We're setting one up for malpractice. We're setting one up for something to do with financial thing. But today we had a nice talk on financial, which was done by Dr. Suresh and Sunil Kaza. So we have this advocacy group where we do one seminar, usually on the first or second weekend of or Sunday of each month. And this time we are honored and very, very lucky to have one of our own, Dr. Rajesh Kakani. He is well known to all of you. He is a very big RP supporter. He has got actually an endowment fellowship in his name. Very, very big proponent of RP. And he reached out to me because all these are, I didn't know about it. He reached out to me saying that he had been audited by Medicare, and that's a threat everybody can have. And he said that he had successfully completed the audit and wanted to share his thoughts, what to do and what not to do during such audit. I mean, these things, when it comes to you, you feel the ground has slipped out from your underneath your feet and you don't know what to do. On the same token, we have actually our esteemed panel of Dr. Rakesh Chandra. All of you know Rakesh Chandra. Rakesh Chandra is an MD, JD, and he is uh, MD from Online Institute, and now he's a practicing attorney, very busy, doing a lot of work, partly charitable in the Illinois area. And he has been also our legal go-to person, and he will be sharing his thoughts on this important topic, and basically giving us some views, some ideas on what we need to do and what we do not need to do. Of course, we have also Miss Barbara Kubuzi. She's a expert biller, billing and coding expert, who also will share her thoughts on what to do, because usually Medicare audits are based on wrong coding. Of course, unless you do something very purposely, usually it is an oversight by the doctors, and it's something which you need an expert coder to be on your side to tell you what to do, what you shouldn't do, when not to overcode, when not to code for something which will raise a red flag. So we'll have this excellent panel, and I'll pitch it over to Dr. Rakesh Chandra, who will be the moderator, and he. Doctor, let me also introduce Dr. Rajesh Kakani. Is an ENT surgeon in the New York area and in RPQLI area, and so he is going to also be telling much more about himself when he starts. So, Dr. Rakesh Chandra, please take over and moderate this session. Thank
Uh,
you so much.
Thank you, Amit, for your kind words. Um, so I want to start by telling you a story of a doctor in Appleton, Wisconsin. So what happened is that he was being audited, and what he did was, which is something that I would ask everyone not to do. It was a cold winter day, and Wisconsin can be very cold. He invited the Medicare investigators in, put them in his record room where all the charts were, uh, fussed about getting them coffee and making sure they were comfortable. And what happened is that they were looking at some charts. But what they ended up doing was that being in that room, they looked around at different things, and suddenly the audit became much bigger and much more problematic than it would have been. And when I talked to him, he said, well, they came in and they said it was just a routine audit. And so I said, Doctor, routine for whom? It may be routine for them because they do this all the time. But unless you're audited every week, it's not routine for you. You should take it very seriously. And from that, several things came out. One is that no investigation or audit is ever routine. So even if they tell you that it's a routine, just remember you're not audited every week, so it's not routine for you. But for the investigator, it is a routine job because he is looking for something or the other which he wants to pin on you. The other thing
Okay.
is that the investigator or the auditor is not your friend. You must remember that. You are not expected to treat him kindly. You can put him in a room where there's nothing but two chairs, a desk, and the charts that he's asked for. Do not volunteer any information. Do not ask any questions except that whatever they can tell you. And you have to remember that the auditor or the investigator is just a messenger boy. We doctors have a tendency that we would like to explain everything away. So when he comes in, you start explaining what is the problem, what happened. Oh, we didn't put in the notes, we didn't do this. The investigator has no power. He is just there to gather information, and he is not your friend. If you just remember that, that is very important. The other thing is that everyone should be prepared for an audit because, as Amit said, it's going to become more and more frequent, and it is your right to make sure that you have an attorney present. Uh, I've often suggested that we need three attorneys if we are going to have a practice. One attorney should be a local attorney, someone who's bread and butter person who can handle little things like this. One should be, of course, your regular attorney who knows your practice and so on. And then, of course, you should have some contact with a healthcare lawyer so that if things got out of hand, they know how to protect you. But having a routine attorney, I found that if an attorney is present, things go a little better. So if you're going to be audited on a certain date, have the person around. Also assign one of your staff to videotape the whole thing. It is your right to do that. And when an attorney is present and you're videotaping, believe me, things go very well. Uh, as an example, I want to tell you, I was audited a few years ago. They gave me a date, they gave me a time. These two guys turned up. They were properly dressed. They were wearing a tie and a jacket. They were very polite. We put them in a room, gave them the charts. They looked through the charts and they didn't find anything. Only thing is, they were helpful. They said, perhaps, Doc, you can this way or you can do it that way because it'll be easier. But there was no problem. They did their work. They went away. We never heard anything. And then ultimately they said that, well, thank you for allowing us to audit. And there was no changes suggested at this time. So with that in mind, I'm going to turn you over to our doctor who got audited. But just remember, no audit is routine. They are not your friend. Do not talk to them because you cannot, they're just messenger boys gathering information and you cannot explain anything away. Uh, just if you remember those four things, you will be in good shape. Of course, the bottom line is please don't do anything like upcoding or bundling things, trying to get more money for a procedure or something like that. Uh, on the other hand, I will also tell you if you underbill, you could get audited too. It's not just overbilling, underbilling can also lead to an audit because they wonder why you, when you could get paid more, why are you underbilling? So don't deviate from what is normal. Be prepared to support what you do with documentation and clinical need and treat it very seriously, because it can be the end of something and it can finish in itself. or it can become a big problem. So, with that, I'll turn uh, things over to our doctor to explain what happened exactly in his case.
Thank you so much. I am going to jump right in. All right. Okay. Let's see if this is. Can you see my slide?
Yes.
Okay. All right. So my only disclosure is that I like private practices. I feel that private practices provide a cost-efficient service, and therefore this presentation is primarily aimed at private practitioners, how to be compliant and how to deal with situation. I want to thank Ms. Barbara Kabuzzi. I have a lot of respect for her. She has been a coding educator of national repute, at least in the ENT circles. And when this happened, I did reach out to her for guidance, and she has kindly agreed to share her time. She has a very busy coding compliance practice in New Jersey, and she works with practices nationally. I want to thank API leadership, especially Dr. Chakrabarti and Dr. Chandra. The thing I want to say is mine, in hindsight, was not one of those, I presume, bad audits. It was what is called a targeted probe and educate audit. But I think an education should serve us well to see how to sort of be compliant, how to avoid the audits, and if you do get audited, what to do. So let's see if I can go to the next slide. Okay. So this was the dreaded letter, okay? It came in a colored envelope, and it said, basically, this is a notice of review. I was in shock. I didn't even, first time, didn't even read it properly. I said, this is it. My reputation is gone. They're going to come after all the retroactive calculations. And I don't know how I'm going to show my face in the physician community, local community. And that's it. I mean, this is bad. I cannot tell you how shocked I was, but then I talked to my family, my friends, and in that shock, I actually forgot that I had coverage for administrative defense for the such situations from my malpractice insurance. But later on, I read it, and it would say that you are being audited for this CPT code that you're using too much. That's at the bottom of this slide, 69210, which reads removal of impacted cerumen requiring instrumentation, unilateral. By the way, that's a whole different discussion, but Medicare only pays for one time, even if you do bilateral. So my reaction, oh my God, I'll lose everything, my reputation, my license. Spoke to wife, friends, daughters. Then I looked at, my records. And then first thing I did was I called a healthcare attorney. And I said, you know what, this is what has happened. He said, okay, you're going to sign a retainer. I signed a retainer. And then we talked. And then I said, you know what, this is more of a coding compliance issue. So I reached out to Ms. Kabuzzi, one other CPC of national repute, and a CPC that I worked with. So 3 CPCs, certified professional coders. And they were all extremely helpful, and they agreed to guide me through the process. Then somehow somebody said, one of my friends said, oh, did you inform your malpractice insurance company? Because whenever you are about to be into legal trouble, you must inform your malpractice insurance company. So I picked up the phone and called my malpractice insurance company just to sort of alert them that I'm in a legal trouble. Okay. But then their staff guided me, oh, you have this coverage that you bought for administrative defense. So we will assign you an attorney, and then we'll take care of this part from a financial perspective. So I had $100,000 coverage. So they assigned me another attorney. So now I had 3 CPCs on my side and 2 attorneys, and I started to calm down a little bit. Just a background for those of you who are non-ENTs, that when people come and let's say somebody has a nosebleed and a hearing loss, and we find that they have cerumen, which commonly is called wax, we remove the cerumen, which pays a small amount, but since we also took care of the nosebleed or dizziness or something, we are allowed to bill if there is a separately identifiable service. So we would bill. So all these, eventually the requests came for records, and all these were when we had billed 99213 with a modifier 25, which is follow-up visit with a separately identifiable service and a cerumen removal. By the way, I use microscope for removal of cerumen in most of my patients, but I don't bill for that microscope. Okay. All right. So again, for the uninitiated, this was a targeted probe and educate, and I would urge every one of you to Google it. There are some YouTube videos about how this process works. But in summary, you get chosen by their data analysis that you are somebody an outlier. So the local Medicare administrative contractor will send you a letter like I showed you. Then they will ask you to review record of about 20, maybe up to 40 claims. And if you are compliant, then you're off the hook. And then they promise not to do that same audit for you for the same code for another year. But if you're not compliant, thanks to the regulations, they would sort of give you an education why your claims were not compliant. And then they will give you 45 days to correct your processes and resubmit, and then 40, 20 charts. And if you this time are compliant, then you are off the hook. If you're not compliant, you get a third round. But if you after the third round, you are still not compliant, I don't know what would happen. Fortunately, I got out. So, sorry. After okay, why? Okay, hang on 1 second. Why me? So I'm an ENT private practice, but my practice is very tilted to geriatrics. A lot of ENT practices have all ages, but I'll go not waste your time, but somehow my practice became very geriatric. And then being a solo practitioner, I don't have power to negotiate with the commercial payers. So we don't take a lot of commercial patients. So we have a lot of traditional Medicare patients. Somehow in the community, I got known for a lot of things, but some of the hearing aid dispensers in my area, they have when they sell hearing aids, if a tiny amount of wax is there, the hearing aid doesn't work. So they need sort of, cerumen removed thoroughly before they can sell a hearing aid. And some of these people have a big video screen in their offices, and they would tell the patient, look, it's not your hearing aid that's bad. You have a lot of wax. So get this wax taken out and your hearing aid will work well. So some of these people started sending patients to me. I'm going to joke and say I think of myself as world's best ear wax remover. So therefore I got that reputation, and a lot of these people come, but very often these people have other complaints. They have nosebleeds, they have balance issues, dizziness, hoarseness, difficulty swallowing, nasal drips, and I take care of those things as an ENT. So some of them are only coming for cerumen, we bill for cerumen, but some of them are coming for all these things, and that's where we bill for the two services. So going back to what did I do, as I told you, after getting the letter. And then after I got settled, I searched the internet, got some YouTube education. One of my daughters is in healthcare policy field. She did her own research and she said, Dad, don't worry, okay? 99% of these people eventually, come out. So then I slowly settled down. Sorry about the slides. Okay. So the next steps, I got my education about the targeted probe and education. I met with the attorney. And then this is, again, a take-home message. If you're going to submit records as a physician, it's your responsibility what is billed and what is coded from your office, even if you have a CPC in your office and a professional biller. So before any bill goes, it's a doctor's responsibility. So obviously, I reviewed records. Needless to say, don't modify your records. And then we submitted the records. And I am ashamed to admit we failed in the first round of targeted probe and educate. Why? Because 2 of the patients were seen on 25th, but the biller entered the bill on 26th, and they were billed for the date 26th. And therefore, that was not a correct coding. And therefore, we failed in the first round. So we went through the second round and we passed. All right, so that was round 2, more records, more education, and finally, thank God, passed the test. That's what I wanted to share. Here are my lessons learned, okay? Number 1, please, 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 if you're going to be practicing, you need to keep learning not only your science, your CMEs, but if you're going to be in private practice, you need to take billing and coding courses. Keep learning about practice management. Please maintain professional society memberships. And I hate to say this, but I say this to my daughters, if you're going to have a foreign sounding name and a color of skin like me, I made it a rule to be at least twice as good, okay? Independent practice, you are already under the microscope. Please, please, please follow the rules. Greed is not good. Greed is bad. For billing, again, Ms. Kabouzi will have more information, but I feel that a medical necessity is important and a documentation is important, okay? You cannot provide a service if it is not medically necessary and then bill for it. And of course, you cannot bill for a service that you didn't provide. I think the other lesson I learned from this episode is try to stay within the bell curve, okay? If you're an outlier in the statistics, that is where you're going to get flagged. And, also, when you're buying your malpractice insurance, please, please consider buying a coverage for administrative legal defense. It's not very expensive. In New York, for an ENT doctor who does not do cosmetic surgery, my malpractice insurance is close to $60,000 a year. But the administrative defense is only $800. So it's worth it. What to do after you get the letter? Read it multiple times. Family and friend support. As Dr. Chandra said, don't talk to anybody without having an attorney on your side. Hire professionals. Learn from all the additional sources. Of course, you're going to respond timely. And the last thing is, please, 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 once you get a letter like that, don't just say, oh, let my office manager handle it. Now you are already halfway up the crucifix, okay? So you need to be sort of pay full attention, and it is your responsibility to submit the records. With that, I would like to introduce Ms. Barbara Kabouzi. As I said, I have a lot of respect for her. Over the years, I've learned a lot from her presentations. And I want to thank her for sparing her time. Ms. Kabouzi, Vijaya, can you unmute her? Ms. Barbara Kabouzi? Okay, since I'm not a host, I cannot unmute her. And it's all Ms. Kabouzi. You can post your questions in the chat box, and we will try to answer at the end.
Hi, everybody. I actually would like to, before I go to my slides, I'd like to address a couple of things based on what Dr. Chandra said and what was just said, just things that I thought of that I didn't include in my presentation. One thing you have to keep in mind, remember HIPAA. When you get a request for charts and it is not from your payer, there are these third-party companies that the payers hire to request your charts. You do not have a HIPAA agreement with them, and they don't have the relationship when it's for payment, treatment, or operations. And so when these third-party companies request your charts, it is a HIPAA violation for them to get your charts. And so do not send any charts to these third-party companies. Let them know that you will send the charts when you get a request from the payer, and then the payer can forward the charts to them. But you will not send charts to a third party where you do not have a business associate agreement. So that's really, really important, because the payers are putting you in a difficult situation. So do not do that. When you get a request for charts from third-party payers, never, although it seems really convenient, you'll say, well, I really don't have time to do it. They'll say, well, we'll come in and make the copies. Don't let them do that, because they're going to take more than they're supposed to get. They're going to take more dates, more information out of that chart, and then, similar to what Dr. Chand was talking about in terms of increasing the scope of the audit, that's what they're going to do. So don't ever let the payer come in and do the work for you, because that's going to hurt you. Don't ever let them do that. Okay. Please keep control of your charts and never give them more than the scope of what they asked for. Okay. So keep that in mind. And also keep in mind, from an audit point of view, when you say in the history, although history right now doesn't matter as much as it used to pre-2021, you say, you copy and paste, or you say no remarkable changes from last encounter. Well, if you're only sending this encounter, they don't have the information from the last encounter. So it makes it difficult to audit that encounter to be able to give you credit for the work, because they don't see what was in that last encounter. So keep that in mind. So you may actually want to take not the whole last encounter, but the part of that last encounter included in this encounter. So those are really important things to keep in mind. So those are just a couple things that I was thinking about when you guys were presenting. Also, someone had asked, aren't the payers ever held accountable for their sins? And they are sometimes, but it's more focused on when Medicare pays them too much. For example, the RAC audits, when they go after them because they're paid based on RACs, which is the diagnoses groupers that they're paid on, and they're actually have been made or asked to pay significant amount of monies back, because they'll change or they're asked doctors to change diagnoses from history of stroke to active stroke, and they get so much more money for someone who's in an active stroke versus a history of stroke, and those kinds of things. And it sort of almost makes us accountable for calling the insurance companies, because you know what? They lie. They break the law, and they lie to us every day. And they're lying to us in our denials. And that's when they're excuse my language, screwing with us. And it's costing us money every day. And actually, one of the things I'm doing, so stay tuned for this, is I'm actually working on writing an AI application to help us with our appeals. And it will bring up the laws, the ERISA laws. Almost 80% or more of your patient's insurance are covered by ERISA, because it's not just self-funded companies, it's any insurance that comes as a result of employment. Any employer-sponsored insurance falls under ERISA. And those same laws apply to ACA plans, as well as Medicare Advantage is covered by something called the Code of Federal Regulations. Again, that's law. And those laws are being violated by the insurance companies daily, multiple times coming into your office. And this AI application will take your remittance and take your denial, and in a HIPAA safe environment, it'll write your appeal letter. Because number one, your staff doesn't have the time to write it. And most billing office or revenue cycle companies, billing companies, don't necessarily have the brain power to write really good appeal letters quoting the laws that are being violated, so that we can call on the insurance companies for violating the law. And if they continue to do that, we then file complaints and grievances with the federal authorities for these violations. So I'm building this in an AI environment. The only thing right now that's holding it up is I'm looking for investors, because I don't have the cash at home. It's not a lot of money to build it, but it's more money than I have in the bank. So that's something I'm working on, to let you know. I didn't mean this to be an advertisement, but that's what it, just want to let you know, related to that question. We have to call the insurance companies on the mat for their lives. So let me share my screen and get my presentation up. Just have to move my why do I have a pencil? Hold on a minute, I'm having
You
problems.
opened the wrong screen to share.
Yeah, you have my
You're
Outlook.
sharing your Outlook.
I know. For some reason, I'm not getting my pointer. I'm getting it. Oh, I know. I'm in annotate. Hold on. Let me stop
You have to
sharing it.
unshare this first. Yeah.
For some reason, first of all, let's put my PowerPoint up, and then.
So you have to first get your PowerPoint on the desktop and then share.
Yeah. For some reason, I had this. Let's do it that way. Okay. How's that look?
Not yet.
Yeah.
Now we got it.
Yeah. Just want to move these Zoom bars out of the way.
To change the view, you will see it bigger screen.
Yeah. Okay. There we go. Avoid audit practice. And just to tell you about me, besides being a coder and a compliance person, and I do specialize in ENT, but I also work in every practice. I also do expert witness work, where I help defend practices. And usually, lots of times, it's single physicians when there are actions by the AUSA or the state against them for what they consider fraud, whether it's civil or criminal fraud. And I want to tell you something as a group of Indian physicians. Quite a few of the physicians that I've helped defend have Indian names. And it seems like as Dr. Kakani brought up, that the regulators go after physicians of Indian names, as well as even the insurance companies. I did a case that was Aetna going after a physician here in New Jersey. And it seems very discriminatory in terms of who they go after, which I think is extremely wrong. And I've brought that up, but I just want to let you know, I think it is wrong. And also they tend to be small single practices. I was involved in a practice in Utica, New York. Another one in upstate New York. I was involved in this one in New Jersey, and they are physicians of Indian descent. And each one we have won, where they have gone after, but it costs the physicians huge sums of money to have to defend, and it interrupts their lives, it interrupts their practices, and it is very traumatic to have to go through. Maybe at some other meeting, you might want to bring me on, and I can tell you the stories of these cases. But they're quite traumatic. But we want to avoid something like that happening, and that's what we're here to discuss. A little disclaimer that this is based on my research, my expertise. It's complete, but I take no responsibility. Your organization takes no responsibility regard to errors, omissions, misuse, or misinterpretations. An ounce of prevention is worth a pound of cure, and you all know that. Why audits happen is because there are billing patterns that are outside the norms. Sometimes that's because, as Dr. Kakani brought up, there is greed. Sometimes there is greed, but sometimes there's a practice that is caring for a patient population that is outside the norm. They're caring for a patient population that is sicker than others. So, for example, the physician that I worked with in New Jersey, he was a hospitalist. So he was dealing with admitted patients that were cardiac patients that all had experienced cardiac problems that it involved admission, and had MIs and problems. So they were all very ill, and potentially had death risks with their cardiac problems. So he was not dealing with maintenance of cardiac patients when compared to other cardiologists. He was dealing with the sicker patients. So he would be more outside the norms than most. So it depends upon what the patient population, the diagnoses, et cetera, that the physician is dealing with. The documentation is unsupported. I am constantly working with physicians on how to get their documentation better. With the new E&M guidelines that we got in 2021 and 2023, it's very important. They actually gave us a gift. We're able to do a better job and to provide the ability to give and supporting documentation to get higher levels of E&M. And one of the terms that I got from a friend who's from Utah is I have to impress upon physicians to think in ink. You get paid for what's going on in your head. You get paid for everything you're thinking about. So if you put everything you're thinking about, even the things you rule out, even though you can't put an ICD-10 for your rule outs, if you put all your rule outs in the documentation, you get credit for it in the problems. You get credit for it in the risks. For example, if you're thinking that you might have to hospitalize this patient, and then you decide to delay and not hospitalize this patient and try to monitor them at home and have them call in and let you know how they're doing instead of hospitalizing them, you get credit that there was the potential that you had to hospitalize that patient in the risk. But you're thinking that, but you don't necessarily dictate it and document it in the chart. Well, then you don't get credit for it. Think in ink. Put all of that's in your head in the documentation, or else you don't get credit for it. So I can't stress more to get physicians to think in ink. Your modifier patterns. How much are you using the 25 modifier? How much are you using the 59 modifier? I'm getting ahead of myself. Your higher level E&Ms. How much are you using the higher level modifiers? But to tell you the truth, if you do this thinking in ink, you're going to be able to support a lot more 99 214s and 204s than you were before. And actually your bell curve is going to shift to the right. Are there complaints? Are people complaining about you? Oh, he only saw me for 5 minutes, and look at this high level that was done. And then as Dr. Kakani talked about, your random selection. You may actually, they have AI and they have programs to randomly select practices to be audited. Who are the players? CMS, the OIG, there are RAC audits, there is UPIC, And then there's commercial payer audits from their SIU units. That's who can be auditing you. You have a lot of people. It's not just the IRS auditing your taxes. There's a lot of different people, organizations that can come and audit you. So clone notes. Please don't clone your notes. They know, they can see now that they have AI. If they do ask for your notes and they get multiple days, they're going to see that your notes are cloned. Don't have clone notes. And it's possible today to not have a clone note. Medical necessity gaps, where you're not justifying the medical necessity for these procedures. As I said, modifier abuse. Time-based coding errors. One of the biggest cases that I was involved in was a Indian doctor in upstate New York, where they went after him because they said, if you look at all of his 99 232s, now it's interesting, this was before we had, we could actually base an E&M on time. Remember, before 2021, you could only base an E&M if counseling was 50% of your E&M, okay? And they said because they had a reference time of 25 minutes on a 99 232, and if you took all of his 99 232s and added them up, it would be 16-hour days. But you don't have to spend 25 minutes for a 99 232. And now that there are time references on your E&Ms, you don't have to spend that time. You just have to have the proper problem data and risk on those E&Ms, 2 of the 3. It has nothing to do with the time if you're not using time. But if you're using time and that time adds up to an impossibly long day, they're going to wonder how you're physically doing that. And that's going to make you stand out and look like someone who is committing fraud. And they're going to be set up for an audit. Doing incident 2 wrong. Now, this is where you can actually get into the time-based problem. And this is where you can get into questions like, how can you be doing this many E&Ms in a day? Is if you're using incident 2 correctly, and you've got a couple of nurse practitioners or PAs, and you're using them correctly, and they're billing under your name, your NPI, and so you're basically, because you're using incident 2, you're billing under your MPA. Let's say you've got 2 nurse practitioners. So in the same time from 8 to noon, you're billing 3 of you a day for those 4 hours. It can look like you're committing fraud. So you can end up being a target for audit if you make sure that documentation is done correctly and the incident 2 is documented exactly pin right, you're going to be okay. But if the incident 2 is not done right, you're going to be in trouble. But using incident 2 could actually set you up for being outside of the norm and potentially being set up for audit, just to let you know, because they are extenders, physician extenders. And when you use incident 2, make sure you're using it right so that you will be successful in supporting it. Not using telehealth correctly. Now, we can use telehealth right now as we've been using it until January 30th. It had ended October 31st, and then they extended it, thank goodness, to January 30th. And I hope they give us an extension forever, because I love the way telehealth has gone. I have a couple of doctors that are in New York City, and there's really no need for me to see them all the time. For me to see them once a year would be great, and then I do telehealth in between. But that doesn't mean they're going to do it. Upcoding, if you are coding wrong and coding at a higher level, that's going to put you on the radar. And coding for services that are not provided. Interesting, Dr. Kagani, when you put the wrong date on that service for the cerumen, they could have accused you as coding for services not provided. And you're lucky that it was a TPE audit and you had the opportunity to correct it. Because if it was another kind of audit, you could have been accused of coding for services not provided. Because when you put the wrong date on something, or you on purpose put the wrong date on it, I see it with allergy services all the time, because insurance companies have limits on the number of units you can have at any one time. So practices will take the units and divide it over numbers, multiple dates. But you can't do that, because when you put those units on a different date than they actually were made, you are coding for services that weren't provided on that date. And that's considered fraud. That could be considered criminal fraud, the stuff that puts you in jail. So that's not good. And so you have to be careful. They call it coding for services not provided. And you're going, but I provided them this service, but you didn't provide them on the date you billed it on. So you have to be really careful. So they use AI and data analytics to look for aberrant patterns, out of ranges compared to your colleagues. That's when they're looking at those bell curves. And with bell curves, they also look at other measures. For example, they look at consultations to new visits. Actually, we don't have as many consultations being used, but we still use them for inpatient, because you bill an initial visit instead of a follow-up visit for someone who's in the hospital when it's an inpatient consultation. Complaints from patients, really, that sets you up. Patients call that 1-800, I think my doctor's a fraud line, to Medicare. Complaints from staff, there's that key TAM. Staff can get you in trouble because they number one, they make a complaint to the office, the manager, or they make a complaint to a doctor and nothing is done about it. You're not responsive to the staff and you don't take care of it. And then the staff gets frustrated. Usually they're not doing it because they're greedy and they want the key TAM bonus that they might get. They do it because someone's not being responsive to them and taking care of and addressing that complaint. You need to listen to your staff and listen to what they're saying. And even if it's not a true complaint, even if it's not something that needs to be fixed, you need to get back to them and explain to them why. Explain to them why what you're doing is right. Or listen to them and say, oh, we shouldn't be doing that, and correct it and get back to them and thank them. Even give them rewards for finding something that needed to be fixed. Be responsive and listen to your staff. Inconsistent pairings, billing female things to male and billing male things to female diagnoses. Overuse of modifiers like 25 and 59 modifiers, which means billing too many E&Ms with minor procedures when it's obvious that that E&M was not a significantly separately identified, or the payer thinks that, and then you have to fight it. That's one of the big things I do for practices, by the way. When you get that audit and then the payer does that audit and they come back and they say, we want a refund because all of these E&Ms with minor procedures are not justified. What practices do is they bring me in, or they bring another person like me in. So I'm not saying hire me. I'm saying bring someone in like me, and we do the audit and we help fight it. There are practices that I've helped them fight these refunds that payers ask them to give back, because we do the audit and find that the payer is wrong. Audits are not exacting, and you're able to show that they're wrong, hopefully because you have good documentation and you've learned that. Another thing that I teach is really good documentation for E&M and the 25 modifier. Other coding and billing rules misapplications that they're looking for. So, the bell curves, they're looking for peaks on the 4s and 5s and the level 3 admissions. And sometimes they're even looking at that level 2, as they did for the doctor that I worked with in upstate New York, and the 25 and 59. They compare you to the same specialty and the same geography. But again, if your patient population is different and you can show it with your ICD-10 utilization, which you can get out of your PM system, running a report, you could show them that your patient population problems are different. Frequency and, as I said, and performance of billing E&Ms with 25s, especially when it's shown that the patient had been there just a week or two prior and had an E&M. How do you justify doing an E&M for a patient that you very recently saw? Then they come back and you're doing an E&M again and the minor procedure. And then coding, like I said, the male procedures and the female diagnosis, et cetera. Frequency and usage of unspecified diagnoses. When you're seeing a patient, you know if something's a right versus a left versus a bilateral. Stop using unspecified diagnoses. You know it to the specificity. And by the way, I blame a lot of the PM systems for that, because you go into the search capability and you put in the keywords and start searching for it, and it brings you to unspecified. You know, you put in diabetes and it brings you up to unspecified, but you know this is a patient that has diabetes with renal failure. But the first thing that pops up when you do the search capability in your PM system brings you up to unspecified. Well, you got to keep digging down lower to find with renal manifestations, because you have to not use the unspecifieds, especially if you're billing a level 4 or 5 because it's a patient with renal manifestations. Okay, you have to use the most specified things to justify what you're doing. And billing for time, and that creates an unrealistic workday. Please, I wouldn't bill for time, to tell you the truth, unless you're billing for prolonged services. You need time to be able to bill for prolonged services, but otherwise I would always use MDM, and that's my recommendation when I work with physicians. Keep in mind that when you're billing for time and you do prolonged services, if you use prolonged services, you bill for time, and then another 15 minutes is prolonged services. But for Medicare, it's different than for non-Medicare. For Medicare, it's 15 minutes beyond the top number of that time. And now it's actually and then with non-Medicare, it's 15 minutes beyond the reference time. And that's why we have that G code for Medicare, because Medicare actually, the time ranges are different. I actually have a chart for that, and I could get it to Dr. Kakani for distribution for people. It's in my presentation for E&M. I have a lot of detail in that. Make sure in your E&M you got your problems addressed, your data reviewed, your risk documented, and your time documented. But remember, your EHR clocks you in and out. But make sure you document any other time that you're spending. For example, if on that day, even before the patient comes in and before you see that patient, if you're reviewing the chart, that time counts. If you're doing work on that patient's chart, there's a bunch of times that are non-patient facing that does count, including your time documenting. But it may not be counted in that in and out time within the EHR clocked time, but that has to be documented in the chart if you want it to be counted. So what's going to happen is a payer is just going to look at the in and out clock time. So if you're using time, make sure any of that non-clock time in the EHR is documented in the chart. Procedure, medical necessity document is really important. When you're doing the procedure, make sure. So for example, in ENT, they do scopes. They have to indicate why they're doing the scope. So for example, if they're doing a laryngoscopy, when they do the exam, they have to indicate patient had gag reflex, unable to adequately visualize, therefore determined to do a flexible laryngoscopy. If they put that up in the exam section, they can then, when they're doing the procedure, Since unable to do laryngeal exam due to gag reflex, performing flexible laryngoscopy. We've got our medical necessity. And then your steps performed in detail in terms of any anesthetic, et cetera, your rationale, any laterality you do in detail, and don't use the same procedure performed on the contralateral side. You have not documented that other side. It's never exactly the same, your findings on one side to the other side. I hate that ENTs do that. The documentation stinks when you're doing a sinus on one side or the other side. They're never exactly the same. Come on, guys. You have to put the details on each side and put the complexities and challenges of that procedure that's unique to the procedure. Put any complications that you found, and getting into, everything's not E&Ms. Things are procedural. You're doing procedures. If you have an assistant in surgery, it used to be you just had to list that assistant in surgery on the top in the header of that procedure note. Now you can't just do that. You have got to say in the details of your note what any assistant in surgery did. You have to say they held the retractor while I blah, 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 blah. You have to say what those extra hands did. One thing that those extra hands did in that operative note to support that assistant in surgery, or else that assistant in surgery cannot be billed. Keep that in mind. The red flag modifiers are 25, 59 or XESPU are your unbundling modifiers. This is a huge red flag. Medicare created the XESPU because they felt that people were using 59 too much to unbundle. So they wanted to know, why are you unbundling? I encourage people, for Medicare, and if your non-Medicare payer accepts the XESPU, use it, because you're telling the payer, I know why I'm unbundling. It's a separate encounter, it's a separate site, it's a separate physician, or it's separate and it's something very unique. You're telling them, I know why I'm doing it. I'm not just doing it to get paid. But if you use the 59, you're saying, I'm not sure why I'm unbundling it. Interestingly, Medicare still takes the 59 modifier, and it is actually still the most used modifier. If I was Medicare, I would be auditing all the 59 modifiers, because I would say, why aren't you using the XESPU? I mean, come on, you should know why you're unbundling them. And so that's really important. The 22 modifier for unusual circumstances is also audited, but do not use that as a reason not to use the increased service modifier. If you have an increased service and it's 25% more than the usual, or more than 25%, use it. Just make sure your documentation supports it. Also, in box 19 of your claim, I put why it's increased. Patient severely, 22 modifier dash, patient significantly morbidly obese. Okay, put in that box 19, tell the payer, give them that information. The 24 modifier, which means doing an E&M during the global period. The 58, 78, and 79, which is doing a procedure during the global period. You need to understand these modifiers. Another educational thing I do for physicians and practices is understanding these difficult modifiers. Incident 2, understand incident 2 versus split shared. You can't use incident 2 when you're in a facility. Incident 2 is only in your office, and understand that. Understand that there has to be direct supervision of incident 2. Also understand there's requirements. You have to have a plan of care. It can't be a new problem. So a new patient can't be seen incident 2, and there has to be a plan of care for incident 2. And it has to be either an employee or a 1099. They do not have to be W-2. It can be a 1099 incident 2, and it has to be in your office. So keep all of those things in mind. And in the facility, it can be a split shared service. When you're doing, if you're doing time, keep in mind that you can't, the overlapping time, you can't count that twice. If both you and the nurse practitioner or PA are seeing the patient together, don't count that time twice. You can only count the linear time that the patient is seeing. Who did what, and capture the time for each patient, because that overlapping time can only be once. On telehealth risk, keep in mind consent, location, your place of service. There are modifier rules for each payer. Keep in mind, you need to know the difference between audiovisual and audio only and use the correct codes. And we have the approval right now through January 30th, not January 31st, just January 30th of 26. Medical necessity are signs and symptoms. So, ICD-10 says signs and symptoms shouldn't be billed when we have our definitive diagnosis. But I have to tell you something. I break those ICD-10 rules because I need to get paid properly. So, for example, when I have, the rules also say that they should pay even when we use the same diagnosis on the E&M and the procedure. But payers don't do that. Payers look for different diagnoses. They break the rules. So because of that, I often will put the sign and symptom diagnosis on the E&M, and I will put the definitive diagnosis on the procedure. So the 25 modified diagnosis, for example, again, I do ENT a lot. So it'll be headaches and nasal congestion. And then the procedure, which is a nasal endoscopy, 31231, will be acute sinusitis. Okay, so that breaks the ICD-10 rules. And when I talk to people who are hospital coders, they get really mad at me. And I say, the day that payers start following the rules, I'll follow the rules. But the payers aren't following the rules, and I need to get paid. You need to have rationale. You should put what the prior treatments are when you're writing your procedure note, which supports that medical necessity, and why you're doing it today. That helps all support when you're writing your documentation, your signs and symptoms, what your prior treatments were, what your rationale is, and why you're doing it today. Templates get you in trouble. Be careful, but templates are also beneficial. So again, just like I was talking about scopes, payers look that for documentation that the physicians look at every anatomic area in a nasal endoscopy. So I actually tell ENTs to develop a template, because I know they look at every one of those anatomic areas, but they have to make sure they document that, because they used to say nasal endoscopy performed, all normal except for septum deviated and turbinate hypertrophy. Well, that's not accepted anymore. They have to say that they looked at the sphenoid ethmoid recess and the middle turbinates. They have to look at 8-9 areas. So now it is beneficial to develop a template that says nasal endoscopy performed, the following areas were looked at, all were positive except, and then they dictate all their findings. So a template is useful for something like that, where you always, it's diagnostic and you always look at something and then you put the findings. That's where a template is useful. But be careful when you use templates, because you have to make sure you put what your findings and what is specific to that patient. Copy and paste, you've got to be so careful about that, because they're going to pick that out right away and put that as a focus for auditing. Contraindications, make sure you don't put that in the chart. I'm working with a doctor now, and she's having problems where she gets targeted on contraindications because she was lazy in the past, and she's like on the radar. Missing exam elements that would be required based on the presenting problem. Remember, even though you're not being counted, your exams are not being accounted in your E&M, you have to have the medically necessary exam and history documented in your in your E&M. So don't be lazy and miss documenting those things. And remember, there are coding myths. The higher complexity means higher code. That doesn't necessarily mean that. And you have to document it. And if I did it, I bill it. That does not necessarily mean things are bundled. You might have done sort of an E&M, but it doesn't justify a significantly separately identifiable. Something might be bundled. And everyone doesn't bill a 99-215, and a 99-215 is really rarely supported. A very small population of your patients are going to be 99-215s. Perform internal audits. That's preventative medicine. Your patients have preventative medicine. You need preventative medicine. Perform internal audits. They can be internal or they can be external. They can be people like me. There are a whole bunch of them. If you don't want to use me, I know a lot of people. My company's CRN, that stands for Coding and Reimbursement Network, because I know a lot of people and in my field, and there are a lot of people available to do these kind of external audits for you. And so, it doesn't have to be a lot of charts. 10 charts for each physician can tell you how you're doing. Denial tracking, track how your denials are doing, and it looks at risk mitigation and also then looks at revenue cycle optimization. And you need to appeal the things, because remember, every denial is not correct. The payers deny things that are payable. And that's where you get into appeals and what I'm working on with my AI program. And peer review. Have your peers look at what you're doing. Have your, switch off with your peers and help each other. When that audit letter arrives, just like Dr. Kakani says, don't panic. It could be that target, probe, and educate, not for recoupment or punishment. Show good faith and commitment to compliance. Remember, having a finished compliance program does not have to be. If you're working on compliance, if every month you're just doing a little bit toward improving your compliance, and that includes like doing your audits, you're demonstrating your commitment to compliance. So that's just as good as having a finished compliance program. So if you're doing something toward compliance, you're showing that commitment that gives you the attaboy credits when they come in and look at you and audit you. That's good. Okay, pay attention to those deadlines. If you don't get your information and responses back by the deadlines, they consider you a failed audit. And they're going to ask for a refund. So always pay attention to those deadlines. You could, like Dr. Kakani said, you get a lawyer to represent you. You do want a lawyer who understands healthcare. Don't hire the lawyer who did your house closing. They're not the lawyer who understands what you're doing. And it's great to have that rider on your insurance. Lately, most of the cases that I'm hired are cases where they have the insurance to pay my fees, which is terrific. I love it when I don't have to get the money from the physicians. And the lawyer will write a letter and get an extension on the deadline if it's too close and you just can't meet it and you're too busy. So you can get extensions on deadlines. And remember that record collection, only give them what they asked for, and take corrective actions for any deficiencies you found. So one of the big things is, if you found deficiencies, start taking corrective action right away, so that when you send it in, you can actually say, we have found that this, and this is wrong. We have already taken the following corrective actions, so that you show that you're in a positive compliance frame of mind, and that you're taking action, and that it really makes a difference in mitigating the damages that you will have to be assessed. So the triggers are risk factors, your documentation, create audit triggers, and your claims. And so yeah, the symptom goes to an exam, just like what you do at medical necessity. Symptom, exam, differential, decision. And I can't read my final box, then the service. Our pictures are covering my final box. So keep that in mind. And now we go to, I hope I didn't run too long, questions and answers. I'm going to unshare my screen and we can go to the chat or whatever for questions.
Where's the chat?
That was an excellent presentation. In the interest of time, I'm going to do the quick question
Absolutely.
answer, and then we'll hand it over to the moderator, and then ultimately to Dr. Chakrabarti. I'm looking at the chat box. Dr. Ramani asked, whether you get a phone call. My recommendation is no, do not respond to any phone calls. This letter came as a mail. There was no phone call associated.
Are you going to give everyone the handouts, Dr.
Yes, I will share the handout here, and this will, with Ms. Kabuzzi has been kind enough to allow us to record it. I think it will be edited a little bit and then will be posted on YouTube for everyone.
Yeah, I also have a couple summary sheets that I put together as well as the PowerPoint for you.
Right. Okay. So I would, at this time, I will yield back to Dr. Chandra.
Yeah.
And while he's doing it, I'm going to try to show the two PDFs that Ms. Kabuzzi wanted to share, she has created. So I'll try to share those, and let's hope people can multitask, listen to Dr. Chandra, and look at these things.
Thank you.
Thank you.
So I want to mention one particular thing which the doctor said right in the beginning, and that is when you get this letter, don't panic. His reaction, which was very normal, is a reaction that all of us have. I mean, I can say that I felt the same, that my life was over, that I was going to be, bankrupt, that people would look at me and say, my God, he must have done something wrong, because they try to publicize this a lot. And what my request to you is that if you are practicing in this country, chances are you're going to be audited or somebody is going to come and inquire about something or the other. Don't panic. It's not the end of the world. You're not the first person who this is happening to, and you're not the last person. I understand there's some trepidation, but you see, what you read and what you hear about in the papers are purposely put there because you're supposed to be scared. You're supposed to think that they are going to find something and your license will be gone and you'll never be practicing, which is not true. They are very fair. Sometimes you run into a prosecutor who, for some reason or the other, doesn't like you, but more often than not, because when I was doing my LLM in health law at Loyola, there were a number of prosecutors there, and they laughed and said to me, "The doc, if we want to nail you, we can nail you. There's nothing is ever perfect, and if you believe, then you have to know that the prosecutors have a lot of integrity. They don't want to mess up a professional's career or life or anything. Unless the conduct is very egregious, they will not do anything." And so the other thing is that we have a lot of resources available at API and other places. So please get in touch with us and we will try to put you in touch with the right person. And of course, like the lady said, do your personal audits. Every 10 charts, maybe every 3 months. That'll go a long way to protecting you. But again, remember, you're going to get audited. Be prepared mentally and physically.
Drive toward Rose Lane Street North.
And remember that it's not the end of the world. You will come out of it more often than not successfully. Don't treat it lightly. Don't treat it as a joke, because it is not. It is a very serious matter. Don't bury it. Don't have your office manager go and do it. Get a lawyer involved from day one and get a coding expert like this network and have them back up your thing. So with that, I'll turn it over to Dr. Chakrabarti.
Well, thank you so much. I mean, this was We have record audience. Nobody wanted to leave. Barbara, thank you so much. I mean, actually, Rajesh, Dr. Kakani, thank you so much for bringing such an amazing person to educate us. People pay money for attending these kind of seminars. You gave it to them absolutely free. Your knowledge is absolutely commendable. I go to a lot of these coding seminars, and I am very familiar with a lot of things which you are saying. I try to code very carefully. Bottom line here is that you should not get scared. If you have done the work, document and bill for it. There's nothing wrong with it, and that's why taking these coding seminars from time to time, keeping up with the changes which they have come up with, are so important. I've got a few things which I want to add on this, if I may, about templates. I use templates quite frequently. I mean, in Epic and any other EMR systems, they have got these fast track things. You can actually put things on there.
I think we lost Dr. Chakraborty.
Okay, so in the interest of everyone's time, if somebody has questions, please, you can raise your hand in the reactions. I will quickly try to see the chat box. Ms. Kabuzi, if you have any closing notes at this time, we have obviously gone over time, so we want to finish.
I would like Ms. Kabuzi to just show us her number, her telephone number. Because I think she's a very valuable resource, and I think we should all take note of it, because honestly, when you're being audited, if you show that not only have you done your own internal audit, but you had someone like her or from her network come and check your charts, goes a long way in establishing credibility.
I will share her information again. Her name was, all the information was in the the handout for the flyer, and I would try to get it. But CRN Healthcare, if you search that website, you would get information. She's very knowledgeable. I've followed her for many years.
Yes.
Vidya, can you unmute?
Tell you something. You did a remarkable job, after your initial shock and initial reaction. I think you did a remarkable job. I want to tell you, not just as a fellow doctor, but as a healthcare attorney, that you really did the right things, after your initial panic. Whatever you did is exactly what should have been done. And I'm glad that you got the help and you came out of it, because that is what the normal outcome should be. It should not be that they're out to get you, or we are foreigners, and there's nothing like that. You may feel that occasionally, but really, believe it or not, attorneys that go and work for the government have very high ethical values, and most of them will not be able to sleep with themselves if they have somehow nailed you for any other reason when you were not guilty. I doubt that, because I talked to them at great length and I said, what do you guys do? And they said that, look, we always try to look at it from the point of view that no one's perfect. Small errors can occur, and we don't treat them in a way. The only other thing is that don't get arrogant with them. Don't get rude with them. These are people who have ego issues. And if you treat them as professionals and with respect, they treat you with respect. So I think you did the right thing.
Thank you so much. I don't know. I got disconnected for a little while. Ms. Barbara, did you hear the comments which I made, or did you guys get a chance?
We were able to get it. We were able to get it. Thank you so much.
Okay.
Can I address? Someone asked about refund requests.
Go ahead. Yeah.
When a refund request is that is not correct, you should dispute it, and note that it is illegal when insurance companies try to do an offset, because remember that the money that you get belongs to the patient. Okay, so when they try to take John Smith's money for Mary's refund, they're taking John Smith's money. That's illegal. And one of the things you all should do, I can send this to you, doctor, for you to share with everyone. One of the things every doctor needs to do is to get a stronger assignment of benefits from their patient, because you need to show from an ERISA point of view that you are standing in the shoes of the patient, which means you are the same as the patient from an ERISA perspective. And so they cannot take John's money for Mary. And that's illegal. And again, you need to fight with them and complain and then file an ERISA grievance on it. You need to hold them accountable and start making their lives miserable about it. Because it's up to us to make, someone said, why aren't the insurance companies called on the carpet for this stuff? Because we haven't been making their lives miserable. And it's going to be like little pieces of sand in their shoes as we keep putting more sand in their shoes, as we call them accountable for this stuff. Because they're doing illegal things. They're taking John's money for Mary. That's not allowed.
You know what?
Vijaya,
I'd like to add something to that for a minute.
Can you unmute the 3 people who have their hands raised so that they can ask their questions?
And these are the 3 people who will ask the question, and then we need to end this session. Yeah. And because obviously we have to put this on the website. After they ask their questions, I'll have the closing comments. Go ahead.
Thank you. That would be the last 3 questions. So I'm not able to unmute. Okay. Vijay, are you able to unmute any one of them?
Yes, Dr. Mittal. Dr. Mittal is unmuted. Yes. Go ahead, Dr. Mittal, please.
Dr. Mittal, go ahead.
Yes. So my husband opened a neurology practice, and I'm helping him. I'm also a physician by training, and we just opened the practice in California. And I was just wondering if you guys have like contacts for all the attorneys that you talked about. Like, is there like a resource of, this is a very informative talk. I'm really, really thankful.
I'll try to help you offline, Dr. Mittal, okay?
Okay.
Thank you.
One of the things that I'm really scared, like, is this the right thing we did with all the...
That's another day's discussion, okay? But don't worry.
Make sure you get, I would look into getting the rider for the defense on your insurance. And by the way, they will provide you the attorneys.
Okay.
Yeah, and your insurance has at least a 50,000 to 100,000 separate fund for defense of your license and auditing and things like that. So look at it carefully and make sure that you are covered for that as a separate thing from malpractice.
Okay, sounds good. Thank you so much. I'm thankful to all the knowledgeable people on this group.
Okay. Just practice and don't be scared. You do the right thing and you will be fine.
Okay, next.
Hi. I just wanted to ask Ms. Kabouzi that, how she said that we're not supposed to give the charge to third parties. So I received a few letters from Optum. Is Optum considered a third party? Because they're asking for patient charts for United and Better insurances.
Yeah, Optum is part of United Healthcare.
So they're not third party then?
Yeah, they're not a third party. They're part of United Healthcare.
Thank you.
Next. Mr. Nikhara.
I do have some sort of unique pattern of practice. Sometimes I have to deal with my patients with neurology as well as ophthalmology. I'm a retina practice as well as neurology practice. So sometimes I have to use this code 99215 because that means I'm not asking those patients to come back again and charging them again by a second visit for ophthalmology. So is it okay for me to utilize in some of the patients 99215?
Well, how often are you using 215?
Well, with my practice being heavily dominated by both the fields, I'm a neurocritical care as well as retina. So sometimes like at 10% of time, at least.
I'm sorry, Anish, I can't understand what you're saying.
So he's a unique kind of situation. He's a neurologist and an ophthalmologist, retina specialist, neuro-ophthalmologist, and he's telling us that his patients are very complicated, and therefore he provides like almost 2 specialty cares, and therefore
Well, then,
about 10% of his bills are 99215.
okay, so you need to really document it. You've got to document. And I have to tell you, on E&M, I find usually where you're supporting it is not on the data. You're supporting it on the problem and the risk. It's hard to use the data because, you know, the data sometimes was ordered last time, it's evaluated now, and you can only count it one time, not both times. I find it's difficult to use the data. I recommend usually trying to count the problem and the risk. And so you have to be able to use that risk column to be able to support that it falls under that. So, you know, are you able to find something that's under the high risk, and are you able to justify the problem is high, or are they falling under the moderate? And just one of those falling under moderate will drag it down to 214.
Great. Thank you so much. Barbara, I need to actually take it over. You have been so experienced and so knowledgeable that, you know, we need to bring you back for another session, and there'll be just session for you. In fact, we're going to do that. Let me tell you, people, we have got a gold circle and a platinum circle. We invite you to become members of that, to get a list of the attorneys and all those things. That is something which we request you to support RP with, and only members are allowed to get these information. So, Rajesh, please, you're a very big proponent of RP. If you're not an RP member, you're actually we'd not be able to give you any of this information, other things which is privileged for members. And anybody who becomes a platinum or a gold member, they have easy access to all the attorneys, and thanks to Dr. Rakesh Chandra, he'll be able to do that. Anybody who wants Dr. Rakesh Chandra's number, I would not like to give that away, because he is a very, very busy practicing, and he just does this as a favor to us, as a favor to RP, and Barbara has done this as a favor to Rajesh. Thank you so much. Please support RP. I really appreciate you. Dr. Kakani, you have done an excellent job. This is one of the heaviest attended seminars, and we have gone more than half an hour over. And I'll reach out to you, Ms. Kabouzi, and ask you for doing this in a separate way, separate session just on this. And I'll reach out to you through Dr. Kakani. Again, thank you very much, everybody, for joining. You guys have been excellent, and I really appreciate the panel, and I appreciate all of you attending. Thank you so much.
Okay, stay compliant, everybody.
Will do. Thank you. Bye-bye.
Yeah, definitely. Thank you. Okay.